Cool. Hi, everyone. Already I'm trying to work out how the tech works. Which way around? Where do I have to point?
There you go. Have I gone too far?
No, that's fine.
Yeah.
Which one?
It's down for that one, but it's a bit temperamental.
Right, okay. Sorry, hello. So I'm one of the neurology consultants in Sheffield. I happen to specialise in functional neurological disorders, so I see a lot of people with things that look like epilepsy but probably aren't epilepsy. So I'm just going to talk a little bit about what I see as what are often referred to as non-epileptic attacks, but I prefer the term dissociative seizures because that's kind of what's really happening. I'll talk a little bit about how I tend to think about people presenting with funny turns and blackouts, and then I'll focus mostly on dissociative attacks themselves. So broadly speaking, when I'm thinking about someone having a blackout, broadly, I'm not a generalist, but these are the kind of things that are in my mind, and I try to then stick that into one of three broad categories of epilepsy or dissociation or, because I'm a neurologist, everything else. So heart stuff, blood pressure stuff, diabetes stuff. Wouldn't be a talk about seizures without some videos. There's a few, so we're just going to, hopefully we'll click through them in the background. But what I find is important to think about when viewing these kind of videos that people may have, or if you're, I don't know, fortunate or unfortunate enough to see someone experiencing a seizure, is to think how you would describe it, how you might document it, and how you might then hand that kind of description over to somebody else, normally either to the hospital, to secondary care, to colleagues at handover. Because what I often find is that pretty much everything we see here could be described as somebody collapsing and shaking in broad terms. I'll move out the way of the screen slightly. So thinking about the type of the movement, the speed, the distribution, the nature of it, how responsive the person is, thinking a bit about the setting that the person's in as well. In fact, we can click on to number 2 now. And how these can all be seen as someone losing awareness and shaking. This one takes a little bit to get going, so I'll just give it a second to play. Yep, he is still going. So again, quite strong movements in this individual. We can probably move on to number 4. Sorry, number 3. I can't count today. Has anyone seen this one before, by the way, number 3? Any Sheffield graduates? Yeah. Okay. That's just a brief one. So number 4. That was provided very kindly by one of my patients. Number 5. And actually, we'll let number 5 play for a little bit, if that's all right, because this one goes through a couple of little phases. So again, it's thinking about what you're looking at analytically, how you might describe it, what kind of features you're thinking about. Sometimes people refer to arching of the back, and I think that's about as arched as a back can get. And then we'll actually skip number 6, and then if you could have a look at number 7. So number 7, there's a strobe light that flashes. The video quality is not the best, so apologies. And then we see what happens after the strobe light. So we'll leave it at that for now. Just keep in mind those videos, but I can come back to them later on if people want to look at specific ones if we have time. But then what boils down normally is we get to the consultation. The patient comes in frustratingly on their own. What's happened? Well, I don't know. And then what do? You say, well, I can refer to the first fit clinic and say, this person had a possible seizure, but they don't know what happened. Please help. And then they come to the clinic to us on their own, and we ask the same question and have the same problem, which is always entertaining. So then the question is, well, how do we know what we're dealing with? And neurologists, right, we love a good history. And I always like to kind of hit it home to say that the history really is very important, I would say, with anything, but in particular with seizures. We love our adjectives, so as many descriptive terms as possible. A witness account is practically essential, I would say, in these situations. So you really need, if there wasn't a friend or a family member or a spouse present, if there was a passerby that happened to call for emergency services. A huge number of places are now covered by CCTV, so with their employer, for example, if they're at work, if there's CCTV footage, essentially as much information as possible to try to understand exactly what happened, because that's really where the diagnosis lies. Is that going to work? Like I say, videos if appropriate. Sometimes sharing videos can be difficult. We've all tried emailing videos and it's a nightmare. WhatsApp doesn't always seem appropriate either. We have a system called vCreate. I don't know if are people familiar with this? So this is like a Dropbox style portal that's okay for patients and clinical use. So the patient is given a link, they can upload it to vCreate, and then we can access it from the opposite side as well. It's really, really helpful. This is how I tend to think about it. I'm not too mean and would ask a junior doctor presenting to me to do an impression of the person's seizures. That's just massively inappropriate. But it should be that if an old school consultant did say, okay, do one of the seizures, could you actually do, or do you know enough about it to be able to reproduce it? So you've got to think about the triggers beforehand, think about what happens immediately before the section of motor seizure activity. The ictus itself, which is the bit that people tend to kind of skip over. They say, well, they had a seizure, and then afterwards they're very confused or disorientated, but they're not really talking about the seizure itself. So you want to know, were they still, were they moving, were their eyes open, were their eyes closed? Was the movement very symmetrical and rhythmic, or was it more random and thrashing and asymmetric? Was it fast, was it slow? Did they bite their tongue? Did they wet themselves? How long did it last? There's loads of stuff about this ictus that's really, really helpful to know, and it's very easy to skip over it. And normally, when you're taking the history from the witness, it's hard to keep them on track as well. So it is important to kind of rewind a little bit and say, okay, I understand, but can we just rewind? Did they do this? Did they do that? What was the situation? The duration, by the way, I always take with a massive pinch of salt. I think in the moment when you're witnessing your loved one on the floor, unresponsive and shaking, it's terrifying, it's upsetting, adrenaline's pumping, time tends to slow down. So a seizure that lasted 15 seconds may well be reported as lasting 2 or 3 minutes. When you actually, if you actually sit and, I'm not going to do it, but if you sit and watch 1 minute, it's a very long time. So I wouldn't pay a huge amount of attention to the duration unless there's something objective, a CCTV camera with a clock on it. And then, of course, you want to think about the post-ictal period, how quickly they recover. In terms of dissociative seizures themselves, just a show of hands, who's actually seen someone have a dissociative seizure? Okay, most of you, fine. But no one in this side of the room, fine. The main feature that tends to be consistent for them is the duration. They tend, typically speaking, to last longer than an epileptic seizure does. But then it's really more about the other features of the seizure itself. And again, I'm generalizing here. There's a lot of variety from person to person. But what I typically see in someone having a dissociative seizure is someone who's having quite rapid, asymmetric movements. You often start to hear words like thrashing or kicking or trembling. You can have the arching of the back, arching of the head. The eyes tend to be closed, often very tightly closed. And we often see some other features as well. That can include things like pelvic thrusting, self-injurious type movements, so clawing, biting, pulling, scratching, things like that. Part of the theory is that may relate to maybe a past trauma that they've experienced. I've talked a little bit about situational and distractible. Situational seizures, I would say broadly speaking, every seizure I've seen in clinic has been a non-epileptic seizure. There's something about certain situations that can make one more likely to occur. Hospital appointments, stressful events, stressful occasions. There's a theory that people with non-epileptic seizures fall down the stairs more than people who don't. I'm not sure how accurate that is. Crossing the road, but not actually in the middle of the road, normally just before or just after. But there's something about these triggering events where there's potentially at least a subconscious need for some kind of secondary gain, some attention, some support. So it's in environments where people may come to help, essentially. Distractibility, again, that's a slightly tricky one, but sometimes if someone is in the throes of a seizure and you offer something to the hand, they may grab that or pull it away or fidget with something. Resisting eye opening kind of speaks for itself. And downgoing plantar responses, it's a soft one, but it can be useful if someone's in more of a still unresponsive state and you don't know, is this an epileptic seizure where the person is now absent and vacant, or is this a non-epileptic process? Then a downgoing plantar response can be helpful. Anecdotally as well, if it is a non-epileptic seizure and someone has ticklish feet, checking the plantar response, you're likely to see a reaction as opposed to someone who is post-ictal after an epileptic seizure and very, very flat. There used to be a bit of a fashion for checking CK and prolactin. I'm not a huge fan of it. A sufficiently violent motor seizure is going to put your CK up a bit and your prolactin up a bit. And either way, you're going to be waiting a few hours for the results from the labs, so I wouldn't bother with that. The face palm, has anyone heard about this? So this is a tricky one, and you have to be sensitive in terms of how you check it. But if someone is genuinely unresponsive and borderline comatose or post-ictal, and they're lying on their back, still and floppy, they have no voluntary control over their body. So if you were to lift their hand and let go of it, it will drop vertically straight down to the ground with gravity. So if that hand is held over their face, it will land on their face, which is why it's important to have your other hand there to catch it if there's a relative present, because it doesn't look very appropriate. Now, someone suffering a non-epileptic seizure or a dissociative seizure, and I've seen this done, I don't know how many of you have done it as well, but you drop the hand and it will land anywhere but their face. It lands on the chest, above, the forehead, the pillow either side, so it can be a useful one just to kind of tell the difference as an active test in the moment. There's another one that I've not mentioned on there actually, which is optokinetic nystagmus. Wouldn't be a neurologist without getting some multisyllabic word in there. Optokinetic nystagmus essentially is if your eyes are open and fixed, and if you are seeing, then there is a tendency to track. So if I look across the room here, I'm trying to keep my eyes fixed, but you'll probably see they are slightly jerking as I track across the room. And that happens in someone in a dissociative state as well. So if they're there with their eyes open, you move something with stripes across their field of vision or rotate their head side to side, you will see this tracking movement, as opposed to someone in an epileptic state where their eyes would just be fixed and move with the head. In terms of actually how to treat them, it really depends on the situation. I think in the acute phase, obviously do your basics, patient safety, A to E, and then once you're satisfied that this is a dissociative seizure and that the person's not in immediate risk, the key thing really is to not panic. Typically people with dissociative seizures may still have some passing awareness of what's happening around them. They can still hear. I've certainly had patients very upset when I've come to see them where they tell me that they don't believe my seizures are real. I said, why did you say that? I said, I heard them saying it on the phone when they were calling the neurologist. So reassure the patient, tell them this is okay, you're in a safe environment. You know, if you happen to have, if someone's had a SATS probe or something on, you can say your oxygen's okay. We know what this is, we just need to let it settle on its own. Just be calm, be reassuring, give some space. Because what we tend to find, the more people, the more contacts, the more attention that's paid to it, it's like just shining a spotlight on it and it's just going to escalate or as a minimum prolong the event. Benzos, I would try to avoid it if you can help it. They tend to be a tricky one. Epilepsy responds to lorazepam, so there's a risk that someone gets given some lorazepam and it doesn't stop it, so they get some more lorazepam and that still doesn't stop it, but it's not stopping it because it's not epilepsy. And then you risk just giving more and more benzos to the point that the person is now medically sedated and needs ventilatory support. And then in their mind, they think, good grief, my seizures are so bad that the last time I had one, I ended up sedated on ITU. So it's really important, to, as long as you've got a clear diagnosis, to try to avoid that slippery slope of making this a very severe medical illness. Placebo effect, I think we all agree that that's not at all appropriate, and we don't do that, and it's not a recommendation. I've had one accidental placebo effect where I had a patient fitting. We put a cannula in case we needed some diazepam, and we flushed it with saline, and the seizure stopped before we got the diazepam ready, but obviously not a recommended treatment. Moving away from the actual moment of the seizure itself and thinking about how we manage this condition in the longer term, or medium to longer term at least, it's really about being open about it. I think we've moved past the days of saying, oh, congratulations, it's not epilepsy, and then being kind of cloak and dagger to our colleagues saying, oh, this is it's non-epileptic. just be open about it. Say, we know what this is. This has positive features of a condition. It's called dissociation. It comes under the category of a functional condition. There are some websites I can show you. The treatment is very different to the treatment for epilepsy. You don't need medications for it. It's more about understanding what's happening and exploring what's happening on a subconscious level that may be driving these seizures. And there's loads of information out there online now. And I think at least a lot more understanding and acceptance of it. Unfortunately, there are still some cynics out there who may be somewhat dismissive of it, and the patients are very, very, very sensitive to that. So I really think it's important to just be open. And if you're not sure, then say you're not sure. Say, well, you're having seizures. There's a possibility of epilepsy, but there's also a possibility that it's this other condition called dissociation. We'll do some investigations. We'll see if we can get one on video, and then we'll have a clear idea of what we're dealing with and how best to treat it. This YouTube video, by the way, is fantastic, Dissociated. It was done by the team in Sheffield. It's about 40 minutes long, so you get about an hour of CPD for it as well. I'm almost at the end, actually. So before we go to these videos again, does anyone have any questions or comments about what I've covered so far? Stunned silence. Go for it, yes. How does it affect driving? So the DVLA used to be pretty vague about it. So they used to say that, whereas with epilepsy it's very black and white, a single seizure is 6 months, multiple seizures is 12 months. And for dissociative seizures, they used to say until they are, quote, sufficiently controlled, whatever that means. Now they say 3 months. So they're just drawing a line under it now, so 3 months for driving. Yep.
You mentioned psychology support.
Yes.
Is that something that you've got available within your department once you've made a diagnosis?
Yes, it's tricky though. So we're lucky that we have an F&D service in Sheffield. So if someone sees me in my clinic, for example, I can refer to the neurology psychotherapy service. It is a small team. They're very, very stretched. So they can only accept referrals via the neurology clinic. I'm not going to do a massive presentation on their service, but essentially it involves an initial assessment, after which the person is then put on a waiting list to start one-to-one therapy. The waiting time from assessment to starting one-to-one therapy is somewhere in the region of 2 years at the moment. Not for the seizures. Sorry, the question was if there's any drug therapy. Not for the seizures specifically, but potentially for other factors around it that may be contributing. If the person's got severe anxiety, for example, if they have severe intractable pain that needs to be managed, that aspect of it may be, but not for the seizures themselves. Yeah, absolutely. And sometimes people may say, well, give them some pregabalin because that's an anti-epileptic and it's an anxiolytic. But again, you've got to know what you're treating. So you say, if anxiety is a concern, I want to treat your anxiety with whatever you seem as appropriate. Mm-hmm.
Was very depressed and had some pain from arthritis in the neck. If you switched them to duloxetine, would that be just
I'm going slightly off topic, but duloxetine I find more for kind of peripheral nerve pains rather than these kind of more central neuropathic pains. But it wouldn't be contraindicated, I'll put it that way.
Should they all be referred to yourselves or neurology or they might present to us with one episode.
Yeah. I think it's a bit of a case by case. I think in an ideal world, then yeah, because then they have the opportunity for that specialist consultation and discussion. But my hope of events like this is that it kind of empowers people in the community to have a clearer picture of it. And if you see something that is so clearly black and white dissociative, then there may not be a need. Otherwise, you're potentially delaying the understanding and treatment for that person. Because if you say, I think that this is dissociation, it's really clear cut. I'll refer you to the specialist service. I know my clinic has a waiting list of about 18 months at the moment. Then I'll refer to psychotherapy. That's another 2 years. So you're looking at close to 4 years before they actually get any treatment in that situation. So if it's uncertain, then obviously refer across. But if it's very black and white, there may not be a need.
What's the aim of this psychotherapy? Is it acceptance or they can come out of this?
It's, I'm not a psychotherapist, so I can't say for definite, but my understanding is it's quite individualized. So sometimes it may be ACT, acceptance and commitment type therapy. Sometimes it's more of a CBT approach, looking at kind of identifying triggering thoughts and experiences, sensory grounding techniques. A lot of people have had trauma, so they may have EMDR type therapy for kind of trauma processing. So it's a bit more individualized.
So they can come out of this?
Yeah. Sometimes, my personal feeling is the best treatment is confirming the diagnosis. just having that diagnostic conversation, that understanding, because a lot of these people are left just not knowing what's going on, and that's just more fuel to the fire. So if they just know what it is, that in itself can be a treatment. Yes? If you shout, I'll repeat it.
Yeah. Would you make a diagnosis just on history, an examination, or would you go with EEG or further tests?
I think a really good witness account may be enough, but some of the tests can be helpful. I think a video is the best test. You probably noticed I've not talked about scans or EEGs or anything, and that's because it is more for epilepsy on that front. The EEG is only really helpful as if they have a seizure during the EEG and there are no epileptiform changes on the trace. The trouble is, even in people with epilepsy, if they're not having a seizure, the brain activity is often normal, and the chances of one happening in that 20-minute window when you're hooked up to the monitor tends to be pretty slim. So I don't routinely do EEGs for these patients. Yep.
Would you classify these as voluntary or involuntary?
My feeling is absolutely involuntary, because voluntary, you're getting into the question of kind of malingering and faking symptoms and so on. I believe that you have to treat the patient as though this is absolutely an unconscious, involuntary process. Otherwise, they start to feel that they're being blamed for their seizures, and then it ruins the therapeutic relationship.
Do they ever co-occur though? Have you
Yes.
ever proved that they do?
Yeah, absolutely. So people with epilepsy may also have coexisting non-epileptic seizures.
Okay.
So then
Someone could technically be diagnosed with the non-dissociative, they could still need epileptic treatment.
Yeah, potentially. And what you often find is that the seizures kind of evolve. So they may present with multiple seizure types, and then some of it responds to treatment and some of it doesn't. Or they present with one type of seizure, you start treatment, that seizure stops, and then a different type of seizure develops, and that's the dissociative one. I'm aware of the time, so could we just play video number 5, if possible? So I showed this video to a group of acute medical consultants, and the vast majority would have treated this as status epilepticus. This is an absolutely classic dissociative seizure. And if we go back to thinking about the descriptive terms that we may use for it, we've got something that is rapid, that is asymmetric, he's got arching of his back, and it kind of changes as well. It's not just the same thing that carries on for 30 seconds and stops. It starts with trembling of the legs, but then it moves to this kind of truncal movement. There's some asymmetry of the hands, and it does kind of wax and wane in its intensity. So this is a classic dissociative seizure. Does anyone know which one of these 7 is the epilepsy patient? For the record, only one of them is epilepsy. The rest of them are all non-epileptic. Number 7? Shall we play number 7? I feel like a bingo caller. So number 7, so she's hooked up to a monitor, she has a strobe light, and what kind of, going back to the kind of descriptive terms for the type of movements, what kind of movements would you consider that? 'Cause I find it hard to think of any other word than jiggle for this one. Should we have a vote? Hands up for epilepsy? Well done. Hands up for not epilepsy. Yeah, absolutely. Yeah, so that's not epilepsy. If you look at number 2 was the epileptic one, so if you can play that. So this is the setting kind of gives it away a little bit. It's clearly someone who's hooked up to a monitor, but what happens for this person is that he stops what he's doing. He actually has an initial focal onset, so he has a head turn and some posturing of the arm. There is a vocalization of the sound, but what happens then is that you have a tonic phase followed by a clonic phase. And this is what tonicity is. This is that real rigidity. It's not just someone who's quite stiff. It is intense co-contraction of muscles, which is very intense, very strong, very severe. And this is why people used to check like CK and so on, because this will put the numbers up. Extremely rigid. You can possibly see that his eyes are open as well, and that his eyes blink in time with the jerks of the body. So it is that rhythmic jerking. If you imagine the electrical discharges going across the cortex, everything goes together. And then it just gradually peters out. But you'll see, as it peters out, the jerks of the arms, the jerks of the mouth, and the jerks of the eyes are all in time with each other. So that's the epilepsy one. Number 3, by the way, is the somewhat famous German medical students video. This is where students were volunteered to faint on camera. So what you're seeing is just after they've been squatted on the floor, hyperventilating, and then suddenly stand up, and that's what happens. And it's just to demonstrate that you can twitch when you faint. That being said, I'm afraid we've probably come to the end of time. Is that right? So I shall leave it at that unless there's any burning questions.